No. Hello, everyone. A very good evening. I am Dr. Himani Narula. I am a developmental behavioral pediatrician, and I thank Autism Connect for giving me this platform to communicate with all the parents, caregivers, and educators, and all those who are involved in taking care of children with autism. And I am a developmental behavioral pediatrician who has got close to 20 years of experience in pediatrics and development pediatrics. And I've also been working constantly in this area and have a small chain of child development centers where day in and out I am dealing with the families, caregivers, and the teachers, educators, therapists who are working with children on autism spectrum disorder. So today our topic is very interesting. Why we chose this topic today was because a lot of times parents and caregivers, they are very confused as to how to get a diagnosis, who will give a diagnosis, who's the right person to evaluate my child. How did we miss this? Our child got turned 5 years and we could not know that our child is on autism. How did we miss this diagnosis? What all we should keep in mind, what is the right time of screening, how is the process of diagnosis happens, and then how do we professionals also consider planning intervention, and what parents need to know when we are thinking or planning about intervention for our children on autism. So if you have any questions about your child's development, about autism, you can post it at our chats as a question. You can also email me. My email addresses are also in the presentation. So we all know that autism spectrum disorder has three main areas where the child or the individual is facing challenges. One is in the social uh, areas, social impairment, social reciprocal responses are impaired. The second is impairment in communication, verbal as well as non-verbal communication. And the third area or segment of challenges is where the individual has restricted repetitive patterns of interest behaviors and activities. There will be stereotypic patterns. So there is a triad. And we have been reading about this triad from the beginning. The current prevalence is very important for all of us to know because in the last decade, it has suddenly increased. The prevalence has risen, and to the tune of that, we find 1 in 36 children are on autism spectrum disorder. There could be various reasons. Our whatever data we have through Indian studies and through WHO says 1 to 2% across the world. WHO says 1 to 2% across various areas. But the Autism and Development Disability Monitoring Network, CDC, has given that it is 1 in 36, which is signifying that there is a significant rise in the last few decades, last 1 decade or last few years. So that's alarming. And the reason could be purely that the diagnostic criteria has got changed. There is more awareness now. People are aware as to what are the symptoms, what are the neurodeviances, and even mild autism spectrum gets diagnosed, which was probably missed out earlier. High functioning autism gets diagnosed. which was probably missed out because they tend to gradually, with time, with their intelligence, tend to overcome their challenges, and that's why they were not able to identify them. So, why we are talking about autism diagnosis, screening, and then planning intervention is because we want to do the diagnosis early in their years. It is well known in research, and there are papers published around the cost that goes into raising a child on autism, and which is way more than what goes into raising a neurotypical child because of all the interventions, all the additional services that are required. So, early intervention, the research says, can save up to two-thirds of that cost for the parents, for the family. So it's very important as a country, as a individual, as a professional, as a parent, to be on high alert and to be aware of the symptoms of autism so that it can be identified early on. Excuse me. Early diagnosis will help us to start the intervention early. And early intervention, we all know, is extremely important for good and optimal developmental outcomes. And it also helps the child to learn skills, to learn appropriate behavior. So it reduces and keeps their inappropriate behaviors less, thereby helping them to get better included in the society, better accepted, their challenges are less, so they can overcome their challenges if we intervene early. And also, when it comes to when we identify early, we can always do assessments, we can do some tests, we can know if the autism spectrum syndrome are secondary to some kind of a genetic diagnosis, and we can, if that can be prevented in the future siblings. So there's a lot of prevention that we can work on. And the parents can be prepared emotionally, they can be very well prepared, they can grab more knowledge, information as to what all they can do for their child. So surveillance, when we say screening, before screening, surveillance happens. That is, in every pediatric visit, the milestones of the child should be checked. Developmental milestones are very, very important, and they are the first, they give us the first cue if a child is going on track, is developing or track or not. Then screening happens later, and screening is technically a standardized process where we use a tool to do the screening, which can be done at 18 and 24 months. And surveillance should happen at every pediatric visit. And in certain situations where a screening is not mandatory in any country, or in any part of the world where the screening is not a mandatory process, there the screening should be mandatory in certain special conditions, such as if the child has a sibling on autism, that child must undergo a mandatory screening for the child. If the maternal age or the paternal age is high, then again, this it should happen mandatorily. If parents or family, there's a family history of schizophrenia or any kind of a psychotic or affective disorders, if the mother has had some history of seizures or history of intake of some anti seizure medication during their pregnancy, like sodium valproate, then those increase the risk, and that calls for our attention that, okay, the screening should happen mandatory for this child because there was a risk factor. Again, with birth defects or any kind of a cranial malformation, or if there are any kind of a genetic diagnosis or suspicion of a genetic diagnosis, then if there are any chromosomal disorders, even Down syndrome children sometimes do have autistic symptoms. So it's very important that we are aware about these conditions, and they call for a mandatory screening in such situations. then whenever the child is coming into a pediatric clinic, or for the parents also who are parents to young children, or maybe going to be grandparents also, or have children raising in their families or in their neighborhood, there it's important for us to know what do we need to know when we are thinking of surveillance. Okay, every child, we must see, is the child making an eye contact? Is the child looking at us? Is the child playing with us? How is the gestures? Is he pointing? Is he showing interest? Is he trying to copy us? So all those early features are like verbal and non-verbal communication. What is the quality of those communication skills are, and we need to check them according to the age of the child. Then social reciprocal responses like eye contact, joint attention. If I'm saying, oh, that's a beautiful plant, the child is looking at it and then looking at me. So, excuse me, there's a shared attention between the object and two people. So that joint attention, social referencing, if you're showing, see, mama, see, papa, where's mama? The child looks at that person. So that's social referencing is important. Shared interest is important. So pretend play is important. So in early years, less than 1.5 year, if we do not see these features, then it is alarming for us, and we need to start thinking of the screening, that we must go for a formal screening. In surveillance, we are just roughly picking up. Okay, the child has come to the clinic. Oh, is he walking? Is he pointing? Is he doing this? Is he having a parallel role play? Okay, he's doing all this. He or she is doing all this. We are good. But if we see, oh, she's not looking at me. She's just busy in herself. She's not responding to name call. This is surveillance, right? So, other features that the doctors must look at is they must check all developmental domains quickly in their 5 minutes vaccination visit, or in their 5-10 minute visit that you're going for a routine cough cold check also. They can quickly look, okay, is the child walking, doing gross motor milestones enough, or maybe ask you, have you observed the child doing this at home? So that kind of an interaction also rules out a lot of things where formal screening is not happening. Vision and hearing is very important, and head circumference must also be checked by the doctors. Now, some red flags which will tell us, which are positive indicators, if they are observed, that calls for a formal screening. Like if there is a parent reporting that he was saying mama, papa, but it's been 2 months that the child has forgotten, he's lost his words, not really saying anything. So any kind of a loss of any developmental skills is alarming. Parental or professional concern is there about the child is not making eye contact, or they doubt that he's not probably able to hear. He's not able to see. He's not fixating, not looking at me continuously when I'm talking. So, is there a visual impairment? Is he able to see, or is he able to hear? So, vision, hearing, both are important. If the child is too lazy, floppy, not really wanting to move, is seated in one place, or if the child is 18 months but is not speaking a single word, is not trying to communicate his needs by appropriate gestures, it is alarming. If there is some kind of a asymmetry in the movement between the right and the left side of the body, or if there is a tightness, the child is not started to walk, or gross motor milestones not being achieved on time, or the child is walking on their toes constantly, or running on their toes most of the time, or if the head size according to the head circumference growth charts, the centile charts is too high, or that also is alarming. Or if it is, if a person or a parent or is not really sure if my child is developing all right and wants to know more, then also that child should be subjected to a formal screening tool. So that is something, because the parent has some doubt that there's something that my child is not doing. My earlier child did everything before this one. I feel this one is running a little late. May not be able to specify a certain thing, what is running late, but they have observed that as per other children in the park, or as per other children around, or as per my previous child, the parents says, no, I think this one is a little slow. Then that also calls for a formal screening. Some indicators where the child is not able to do certain things, like if the child is holds an object placed in hand by 5 months corrected age, or reaches out for objects by 6 months, if the child sits unsupported by 12 months, or is not walking by 18 months, if the child cannot do these things which are written here by this age, that calls for attention for sure. If the child is not able to point or share, point means using their index finger. Okay, this is what I want. That lying there, I can't reach there, but that's what I want by 2 years, or is not able to run independently by 2.5 years. If these activities are the child is not able to do at the mentioned age, it calls for a formal screening. What is important again for us to know is that four important points you need to keep in mind. The earliest symptom is not an abnormal behavior or abnormal stimming or a stereotype that you will see. It is the absence of normal development, normal behavior. So that is going to be the first sign, first cue that something is not right, and we need to find out what is the reason for it. Then second is, if there is a parental concern, never ignore a parent is the rule for the professionals, for educators, for social workers, for doctors, nurses, whoever is dealing with a child. Never ignore a call of a parent. If the parent has even slightest of concern, as professionals, we must get into the detailed observation and perform a screening there. If there are extremes of temperament in behavior, like suddenly the child will start laughing, and then suddenly the parent doesn't know what is the reason and the child starts crying. So that also is alarming. Sudden behavioral shift, being very moody, and regression of social skills or speech at any stage is alarming. Second is screening. So after surveillance, we come to screening. Surveillance, we know now we know that we have to screen, we have to look for milestones in every child. If we find delays, we need to reach out. Certain things, if the child is not doing at a cutoff age, we need to get a screening done. And now screening, why? What is screening? Screening is you use a standardized tool to find out if we are running developmentally on the right path or not. So it's a standardized tool that must be used. So it's ideal that every child must undergo a standardized autism screening at 18 and 24 months. However, if every child cannot be done, then in that case, the points discussed earlier, risk factors, if they are there, then one has to definitely consider. So at 18 months again, what is the tool used? It's mostly mChat. You can download the tool very easily. mchat.org is the site where this tool is very easily available. And it's a 20 questionnaire, also available in various languages also. And at about from 16 months onwards, it can be used for screening, for a formal standardized screening of a child. Sorry. So once it will evaluate your social communication skills, parent education is very important. If you doubt something for a child less than 12 months, then we do a regular milestone check and call the parent again after 3 months. But however, if the child is between 12 months to 18 months and you don't have a formal screening tool in your country, most pediatricians would know what are the standardized formal tools which are used in their own countries. And people can they can have their own tool by the Pediatrics Society, or they can have a validated tool for the local population, standardized to their guidelines, right? So that can be used as well. So important is to use a standardized validated tool for the screening of autism between 18 to 24 months regularly. If no tool is available, then also we need to keep this in mind. Okay, from birth onwards, the first thing that we get is social milestones. Child looks at us, makes an eye contact, and gives a social smile. The social smile is the first milestone, which is marked in a developmental checklist. Similarly, then comes the non-verbal communication. Child will start pointing, will start looking in the direction where you are looking, where you are showing. Then we'll start speaking simultaneously, mama, papa. By 18 months, we'll have 5 to 10 meaningful words. And so the sequence of events is like this, and the symptoms also come like this. So the earlier the child, you need to first look at social milestones, then a little grown up, then non-verbal communication, then verbal communication if it is not there. The repetitive, restricted patterns, stereotypes, the sensory issues, they tend to come a little later, or you will observe those symptoms which mostly are observed and the diagnosis is made, they come later. Between 2 to 3 years is the time when the child starts showing those symptoms. Early years, it's very difficult to find those symptoms. Some of the children may show right from 16, 18 months also, but in very early years, especially infancy, it's difficult to pick up. So early signs would be for 6 months, few or no big smiles, no warm, joyful, engaging expressions. At 9 months, no back and forth sharing of sounds. At 12 months, no babbling, no back and forth gestures, pointing, showing, waving. And at 12 months, again, no response to name. So name call response starts at 12 months. But if it is not there, it starts showing us an alarm. And at child will start having 5 to 10 words. If they are not there, or if there is no single meaningful word at 16 months, that's alarming. If you do not know any of these, then maybe just these three things you note down at 18 months. If your child looks at you and points as to what she wants, that she wants to show you, pointing. Yeah, I think we were facing some connectivity issues earlier on. So I'm sorry for that. There is some network issues. I'm not sure which end the network issue is, but we will quickly resume here. Yeah. And I think you can also. So, if MChat is a 20. So 2, 5. Well, okay. Am I audible? I'm sure I'm audible now. My network is fine, but I don't know what is happening at the other front. I hope I'm audible now. Okay, so I'm audible. Great. So we are going to use this MChat screen where there are 20 questions and very easy to need to answer. Their examples are also given. 2, 5, and 12. These three questions, if the answer is yes, we score it as 1. And rest all questions, if the answer is no, we score it as 1. And then we add up the total. So if the total is 0 to 2, it's no risk. But it is 3 to 8, it is moderate risk, and 8 and above is high risk. So if your child scores 8 after you answer this tool, and you can also go online at mchat.org's website, and for your child, you can do a self-screening also. And if you think it's alarming, it's on high risk, you need to reach out to your pediatrician or whoever is your developmental expert in your space, and get a formal assessment done in that. Very high risk child needs to start on intervention. So 8 and above score, between 8 to 20, if there is a score, then the child needs to start intervention and plan for a formal development assessment. Okay, so you can have more screening tool country specific. You can use any of those. For diagnostic assessments in India, we use Inkling tool, uh, which can be used between 2 to 9 years of age. It takes about 45 to 60 minutes. And we have an Indian scale for assessment of autism that also can be used. Whereas worldwide, ADOS and ADI are very considered as gold standard and standardized tool for making diagnosis. However, if some place the professionals do not have any of these standardized tools to help make diagnosis, they can follow DSM-5 criteria. So the criteria has a set of criteria where there are features around social and communication delays. Then there are B set of criteria where the child has four criteria like stereotypic repetitive speech. It can be motor movements like flapping, spinning, rocking, or use of any object, like they'll try to play with the wheel of a car, or instead of looking at a whole object, they'll just take a part of the object and play with it. Those kinds of symptoms. Then there could be excessive adherence to routines. If their routine is changed, they become restless. New place taking transitions is difficult. Very fixated patterns. Speech may be repetitive. Even behaviors can be repetitive. The play will show repetition, and there will be a extreme resistance to change. Resistance to change to the extent to cause the child discomfort and anxiety. That becomes a symptom. Then highly fixated interest, that they would want that particular toy to be there all the time in a certain way. Fixated, they would want to do the same thing again and again in the same way. Same YouTube video they would watch again and again and again, scroll and watch the same song here. They hear the same they would watch the same cartoon again and again, play with the same toy in the same way again and again, putting things in, taking them out. So those are also observed. Then sensory difficulties, hypersensitivities to various sensory inputs, or unusual interest in sensory and aspects of the environment. So those kinds of symptoms, when they are there, uh, then you start considering. And C and D criteria are when the symptoms are present in early childhood, but they may not become fully manifest until the child social demands exceeds their limited capacity. This means that a lot of symptoms will not present, as I said in my triangle slide also, that a lot of symptoms may not present in the early childhood. As the child grows up, their demands increases, they need to socialize and they're not able to do. That is the time when restrictions, stereotypes, they start appearing. So, but the symptoms in general, social communication symptoms will start appearing early. And lastly, the D criteria is important, that these symptoms have to be to the extent to impair your child's everyday functioning. So when these A, B, C, D criterias are met, then also we can make a diagnosis based on DSM-5 criterias. So the professionals, the teachers, educators, they can follow these guidelines as well. Of course, assessment for vision and hearing is a mandatory thing and it must happen. We must also look for the intellectual ability of a child. Lot of children can be having intellectual delay as their or global developmental delay with some autistic features, and the diagnosis tends to get wrongly made there. And assessment of comorbidities like speech, sleeping difficulties, gut problems, dental problems, or other behavioral concerns like ADHD is there sometimes as a comorbidity. So we need to look for those during our assessment. A child always has to be assessed as a whole. It is not just the autism that we are looking for or digging into. We need to look at the child as a whole. We need to look at their nutrition also, their deficiencies also, their growth also, their feeding practices, their sleep, everything has to be looked into and everything has to be managed. So now coming to, okay, we have successfully, let's say, made the diagnosis of autism now, but we want now to plan the intervention. So we won't make it too long for you all, but few tips that we need to keep in mind when we are planning intervention. One and most important thing is that the intervention, whatever you plan, the parent has to be involved in doing the intervention, understanding the intervention, and learning what has to be done at home. Second, always get a developmental assessment of a child done to know what is the developmental level of the child. If the child is 4 years old, but the skill set is at 2 years, you cannot teach the child a skill set of 4 years because the chronological age is 4. So we need to know do the assessment to know the developmental level of a child. The developmental level of a child is, let's suppose, 2.5 in gross motor skills, 1.5 in communication, and 1.4 months in social skills. So your intervention plan must focus at building the skill from their developmental level and not from their chronological age that they actually are. So intervention planning has to be done like that. Then intervention must focus at all domains of the development. Intervention cannot just happen at teaching them only social skills or only communication. A lot of times we see that the whole focus is at making them speak because they are not having speech. Is the whole focus is at making them speak, while we are missing out at social skills, we are missing out at communication. There may be some fine motor difficulties. A child may not be independent, is not doing things, is not feeding by himself, and we are ignoring that. We are only making the child speak after us. So any intervention that we are planning, it must focus at all the developmental domains. That is their physical skills, gross motor, fine motor, their self-help skills, adaptive skills, which we call, which helps them to perform their daily activities. Then it must focus at their communication, verbal as well as non-verbal. If a child is not verbal, then also we must try and teach them communication through various other methods. The child should, it's the more important thing is that the child should be able to communicate rather than be able to just speak, right? And the fourth is social domain, and then the cognitive skills. How much is the cognitive skills? A lot of our children on autism have excellent memory and they tend to learn things, but are they able to understand the concepts of it? So there also we need to work and help them generalizing their small learnings that they have. So don't focus at all the developmental domains. And the last and very important tip is that the development happens in a sequence. The milestone come in a sequence. We see that the child first holds their neck, then the child rolls over, then starts sitting, then standing, and then walking. So now, similarly, all the milestones in different domains come in a sequence. We cannot expect the milestones that, oh, the child will start walking before he starts sitting. That we have never seen. We always see that the child starts sitting first and then starts walking, right? So developmental milestones come in a sequence, they follow a pattern, and we can't teach the child a higher skill before teaching a skill which comes first, right? So if the child is not able to grab thing, we can't straight away teach them to hold a pencil and write. First, the child has to learn to hold the pencil and then be able to mark on the surface and then join two dots and then start copying lines and then start making circles. So things happen in a sequence. So when we are planning their intervention, we have to teach them also in that sequence, in that same physiological sequence in which the milestones occur. We can't teach them a 4-year-old milestone if the 2.5-year-old milestone has not appeared. That's what I want to say. So for all those people who are planning intervention, it's very, very important that these 4 things you must keep in mind, and you must make sure that you are fulfilling these. Parent support, supporting parents, training them, partnering them in intervention is very important, because natural environment training can happen only at home with parents, with family. It cannot happen in a therapy center. So it's very important that the parents need to be partnered in the process of teaching the child. And as the parents partner, they start getting equipped in teaching them the skills, and that improves the outcome tremendously. So the therapy centers, the therapists, the interventionists are just guiding the parents through that journey, through that process. But it is always a team, multidisciplinary team of people. One person cannot teach everything. So take support from different specialists. In if the child has sensory issues, you must get an opinion from an occupational therapist who will guide with the sensory processing disturbances, then speech language pathologists, behavior therapists, educators, psychologists. So there's a whole bunch and a team of professionals who are required and to be able to help the child learn all these skills and guide the parents through this journey. But yes, parents' motivation, mental health of the parents is equally important. And if the parents at any time feel that they are feeling low, frustrated, don't know what to do, are they doing the right thing for their child, or they feel that they need to talk to someone, don't shy away from it. It is all right for people to struggle with some things and to seek help. It's all right. Everybody does that. It's completely natural. So parents, you also need to take very good care of your own physical, mental, emotional health so that you can happily do and happily parent your unique child, right? So I think that is all from my side today. Let's see if we have any questions in the chat box for us. Uh, can we have the questions? If we have any of the questions that you have, please feel free. Otherwise, I've also shared my email ID in the presentation. You can email me your questions. Very happy to answer and support you in best possible way that I can. So I am waiting for the questions. So if we have any questions, do we have any questions? You can put in the chat box and I'll be happy to answer. Okay. Do we have any questions? If we do not have questions, I think we can sign off for the live stream, and see you all and wish you all good luck. And please share your queries on email. I'll be more than happy to help everyone. Thank you. Thank you and good night.